Detroit is an old city. Detroit has many resources and community partners and organizations, including block partners and block organizations that have really been helpful to us. Also, the faith-based organizations provide an avenue for partnership as well as for assisting us in making sure that bottom line, as a researcher, sometimes you're very interested in your recruitment, your enrollment of participants, and retaining participants in a study. Mm-hmm. And these partnerships can help in building that and assuring that our research is appropriate. The supportive social networks. You have history of families working together, communities, and that also assists us, and then engaged community members and organizations who are committed to assisting us with serving as sites for our projects, assisting us with the recruitment of participants, identifying how better to recruit participants, how should we focus on diabetes prevention, for example. So Yolanda and I serve on the Health Literacy Steering Committee, which is focused specifically on diabetes prevention in youth, 14 to 17 years of age, who have a first-degree relative member with type 2 diabetes. And one of the primary ways that we were thinking about enrolling is that there's a focus on obesity and overweight. But as a steering committee, we discussed how we couldn't really post flyers in high schools and trying to recruit individuals who were 20 pounds or greater overweight. That wasn't going to happen. So we talked and we discussed about how we wanted to prevent type 2 diabetes, and as a steering committee, we decided we weren't going to focus on overweight. We were focusing on African American, Hispanic, first-degree family member with type 2 diabetes, but the overweight was not going to be our primary focus and listed in our recruitment materials because we felt that that was going to be not only, people weren't going to respond to it, right, but we were trying to prevent type 2 diabetes in a high-risk community. And just because someone wasn't overweight at 14 years of age didn't mean that we weren't going to see them gain weight or, become at higher risk. So we discussed that as a group, as a steering committee, and we've since enrolled everyone. And in the end, we had 60% of the children enrolled who were overweight and obese.
So another reason for taking a CBPR approach is due to the history. And so historically, research has rarely directly benefit and sometimes actually harm the communities involved. And this is a quote from, or a statement from Alex Allen, who was one of the founding members of the Detroit Urban Research Center, and he is the former director over a community center, which used to be really an active community center. So it was one place in which we know that you had access to the community through this community center. And when he joined the board, he also made a statement that I want to read to you in a second. But he also quoted the parachute model of research as being when research has rarely directly benefited and sometimes actually harm the communities involved, and it resulted in an understandable distrust and reluctance to participate in research. Traditionally, as stated by Mr. Allen, traditionally researchers have excluded communities from influence over the research process. The most well-known example is the syphilis study at Tuskegee. It is what some people have referred to as the parachute model of research, where the researchers drop in, collect data, and disappear without any feedback of the results to the community. This has resulted in an understandable distrust of and reluctance to participate in research of the part of the communities. And you may see this in your own community. I'm sorry, this is the quote from Alex. Our responsibility at Butzel is to be the kind of gatekeepers of the community and of the university, and if the university was going to come in and do any kind of project, that we need to make sure that what they were going to do, they weren't going to do it in a way that raped the community. So coming into the table with that in mind, I came to the table very antagonistic. I was not really going to give in to a lot of what the university wanted to do. More so, I was going to make sure that they were limited as to what they could do and not really take advantage of the community. And that's what Alex's feelings were when he joined the URC. Another reason for taking the CBPR approach is the recognition that public health interventions have often been less effective because they're not always tailored to the concerns and cultures of the participants. And quite often you have people who have these wonderful, wonderful projects or initiatives or programs that simply do not work, and it's because they did not consider the culture, they did not consider the complexity or anything that was going on, as Melissa just, or Dr. Valerio just mentioned.
Melissa,
in the communities. And we see it all the time where, researchers cannot gather participants, they cannot, have a successful initiative because they forgot to look at the community. And public health interventions rarely include participants in all aspects of the intervention as CBPR does. CBPR includes participants in the intervention design, implementation, evaluation, and in addition, interventions of traditional public health often focus on the engagement and influence of community members does not engage the community members again. This approach represents a critical distinction from what is sometimes referred to as community-based research, which focuses on conducting research in a community as a place or a setting and has limited community involvement, if any, in what is primarily a researcher-driven endeavor, hence the phrase community-based research.
So the historical roots of CBPR have been written about by MICHR and Wallerstein, as well as Israel and Schultz at the School of Public Health here. And it is rooted in the belief that traditional outside expert approaches to research may not be the best. And we've had two examples of comments and testimonies from community partners that illustrate that. Also, the disillusionment led to a demand for collaborative research that addresses locally identified issues. As Yolanda mentioned, many times the priority issues that we as academics or researchers identify may not be the priority of the community. So we need to work together to identify what is the community's priority, how does it link back to the priority we've identified through a needs assessment or capacity assessment process, and see how we can work together to address the issues. It is not a method, but orientation to research, so it's a CBPR approach, community-based participatory approach. Our research methods are still, we're going to discuss those in detail, but they still include rigorous randomized controlled trial designs, and we make sure that we have both an intervention and a comparison group. We discuss language as needed. It's not a treatment and a control group, but an intervention and a comparison group, and we'll talk about that as well. It involves consciously blurring the lines between the researcher and the researched. So it is participatory. Those that are being researched, by definitions, the community members are partners with us. So they are involved in setting the agenda for the research, identifying the problem, working on the research design, coming up with that, talking to, as a group about the recruitment processes, the analysis of data, and are involved equitably in all aspects of the research. So it is born from the work of Kurt Lewin on group dynamics and organizational psychology, primarily based on action research. So we are going to translate this, the findings. There is an action component. It is expected that we will have some results that will be allow for some action. Believed that involving people affected by a problem in practical problem solving led to a better solution. So we again believe that involvement of the community partners allows us to better identify, not only identify the problem, but identify the solutions. And it does, it's a reflective and cyclical process of fact-finding, action, and evaluation. So the pilot work that we conduct is automatically reviewed by our steering committee partners. It's reported back to our board, and then there is that reflection of what does this mean? What is richer for me as an academic is having the conversation with my partners in, well, that, what I see as an unexpected finding, or they will say, well, not really. And Yolanda always does that to me. They will say, no, this is why, and this makes sense because of this. So looking at the findings is very, within a community setting and with the community partners is actually very valuable for me as an academic, and then making sure that we then begin the process again. What are the next steps? So we are continuously working on identifying the research agenda together. So I wanted to show Sherry Arnstein's ladder of citizen participation, because in CBPR, a lot of times we're going to talk specifically about community-based participatory research. There's community-placed research as well, and community-based research. But looking at the ladder of participation and engagement of community, you see how therapy and manipulation are the bottom rungs of the ladder where it's non-participation. So many times we as academics and researchers think we know how to help, we know how to cure. So we go in and we are truly providing therapy in many ways that we are not engaging the community. Then there is a tokenism, which are rungs 3 through 5, where you inform a community of what you wish to do. What you come into a community, have a community meeting, and say, this is the research I'm going to conduct. This is what I'm doing. It's consultation and placation, but it is not working in partnership. Then when you have this empowerment of the community and a translation of citizen power is the top 3 rungs, which are partnership, delegated power, and citizen control. And with CBPR, we actually go between those top 3 rungs in many ways, from partnership all the way to citizen control. And I'll share one example of citizen control in my own research. As an assistant professor, I came to the URC board meeting and proposed conducting health literacy related work for caregivers of children with asthma. And I was sent out of the room, and Robert's smiling because, and Yolanda, I think you were there at that meeting as well. And they said, we really want to work with you, but we want to focus on diabetes prevention in youth. And I had been in asthma research for 5-6 years, and as a young investigator, I know those of you that are seasoned professors are saying, oh, she just shot herself in the foot. And that was what people said to me, but I wanted to practice using CBPR methods and the approach. So that was important to me, and I made the decision to continue to be engaged through the URC and work in partnership with communities on the priorities that they set. So I then went back and learned about type 2 diabetes, and now am successfully working in that area as well. So it's this partnership and this citizen control. That's an example of how that control of you want to partner with us, you come in, but this is what we'd like the issue to be.